is Clive Newman. I'm the Director of Primary Care for Derby and Derbyshire Integrated Care Board. I'm here, I hope you're here too, to talk about access to general practice, and particularly talking about the GP appointments, and why really we are struggling with access to GP appointments overall. I've only got my laptop in front of me, so I'm afraid I can't see the chat. So what I will propose to do is just try and go through my slides relatively quickly. Please do put in the chat if you've got comments or questions, and I'll try and pick them up. Or obviously you can save them up and we can have a wider conversation at the end. I don't stand on ceremony, so do feel free to ask me whatever you like, and I'm happy, as we were saying at the very start of this meeting, to have a quite a wide-ranging conversation, because I know there's lots of different elements to this issue. So that's how I suggest we run this. In terms of me, as it says there, I'm the Director of Primary Care, and effectively what that means is that I'm the person that is responsible for buying services from general practice on behalf of the general public, and of Derby and Derbyshire, and also making sure those services are as good as they can be, are of the right kind of quality, and that we have the right kind of range of services. As some of you may know, general practice is slightly different to some other elements of the NHS in that it's a national contract. So there is a national contract set by the government, which sets out the kinds of services they offer and the funding for them. And that is how practices get most of their money. So what we do locally is we make sure that that works, and we commission that contract properly. And we also add to it with some local commissioning of some services that we think the people of Derby and Derbyshire need specifically. So some of what I do is dictated, a large part of what I do is dictated by national policy, but obviously it's about how we interpret and deliver that. And then we have a local element too. Okay, so what I'm going to try and cover today is a few questions I thought people might have. Why is getting a GP so difficult? How many GPs do we have? Is the situation getting worse? Have GPs stopped doing appointments face-to-face? Why do they always tell me to ring back? Haven't we put lots of money into general practice and into groups of general practices? Is there a national plan here to improve it? Is there a local plan? And some of you may have heard about the GP. Well, it's actually it's not a strike. It's a collective action. It's a kind of work to rule. So what's happening with all of that? So those were the things that I thought people might want to ask, and those were the things I've set out in my slides. But obviously, as I say, we can do more afterwards. Right, I'll click us forward. So covered my own sessions there. Those were the questions I thought we should try and cover. So let's jump right in. Why is getting a GP appointment so difficult? I think primarily this is a matter of supply and demand. We have more demand than we have supply. We have, over the last, well, since 2010, we've seen a significant increase in the number of older people. We've had a 30% rise of people over 70. You know, you won't be surprised to hear that, unfortunately, the older we get, the more we tend to need health services, and particularly general practice. So although the 30% increase results in a significant amount of work and demand. In addition, and this is really we're a victim, I suppose, of our own success. We are able to do more and more in general practice. It's more and more sophisticated. So people live longer, but they live longer with often multiple complex care needs, which means that they need more from general practice and from the health service more generally, which is obviously a good thing. It's good that people live longer, but it does mean that demand has increased. The actual overall number, although the number of staff has increased, and we'll go on to talk about this in more detail, what the kinds of service we expect from general practice has also widened and expanded. So their general practice as an organization or as a set of organization is doing more on a wider range of things. And although new people don't necessarily provide what we might think of as traditional GP appointments, and in fact, the number of GPs themselves and the number of practice nurses has remained about the same. So it's increased slightly, but it's more or less the same as it was 10 years ago, where, and in fact, as I've said, demand has increased substantially since then. Let me move us on. I think I've Oh, now I've messed with my own slides. Okay. So how many GPs do we have? Some basic things. We have, I'm not sure how many, hold on, sorry, just messing with my own slides. We have there are not that many GPs. There are about double the number of consultants in hospitals as there are GPs. And the number of senior GPs, so these are GP partners, the GPs who own and run their own practices, has fallen by about a third and replaced instead by GPs working on a salaried basis for the remaining GP partners. And we'll go on to talk about that in a bit more detail later. Overall, there are 730 plus whole-time equivalent GPs. There are more physical people because most GPs, in fact, probably the vast majority of GPs now are not full-time. They tend to work less than full-time, and that's partly because of the complexity and pressure of the job. But it's also because we have more female GPs than male, and the female GPs tend to have other roles. So they often have kids and have perhaps more of a role in looking after their families and choose to work part-time. Not that men don't, but I think that is one of the factors that we now have seen. We have more GPs working part-time. We have about 300 plus nurses and 270 other staff that provide direct patient care. And when you look at, and the graph on the other side there shows you that actually overall, as a kind of comparator against hospital doctors and the overall population, the number of hospital doctors and the overall population has risen. The total population has risen. The number of overall GPs has fallen. So where hospitals or hospital doctors have grown broadly in line, GP numbers have fallen. This is national rather than local, but it will be reflected in our local numbers. Is it getting worse? Well, I think it is hard to tell. We haven't got a lot of data that goes back a long way, but I think it would be fair to say it probably is worse than it was. And certainly the patient survey information, we do a national patient survey, suggests that patients themselves generally think it is. The number of appointments overall has increased. So we started seriously recording or properly recording the number of appointments back just before the pandemic in 2019. And actually the number of appointments we've offered in the last 5 years has risen by 12%, which is significantly more than the number of the increase in GPs and nurses and staff. And we offer more appointments now than we ever do. So we ever have done. So we offer over 500,000 appointments every month, GP appointments and general appointments in general practice. These aren't necessarily all with GPs, but appointments in general practice, we offer over 570,000 a month on average, which is significantly more than ever before. That doesn't necessarily, as I've said, mean that we're meeting the demand. Is face-to-face access worse? I would say not, or not significantly. About 3/4 of all patients get seen face-to-face. It's slightly down. It's fallen since 2019 by about 4%, but we have seen a significant growth in the number of phone appointments. So they have risen by about 20%. It fell sharply, of course, during the pandemic, but has picked up and is now higher than it was before in terms of overall numbers, as I've said, since then. We have about 70% of people get seen face to face, about 20% of people are spoken to on the phone, about 10% of appointments are online. About 4 in every 10 appointments are offered on the day that the person gets through. It says here on the same working day, and that's true. I think what that doesn't reflect is that, as you will know, people can struggle to get through on the phone. So that doesn't account for the fact that you might have tried 3 days in a row, and then when you do eventually get through, you are offered an appointment that day. But it's not the same, is it, as being able to get through that day and being offered an appointment that day. And just over 80% of appointments are offered within 2 weeks. So one of the things we are trying to count or measure is how long do people have to wait for a GP appointment when they get through. Typically, as I say, most people are seen within 2 weeks. Difficult to measure this because sometimes you want an appointment several weeks ahead, or for lots of reasons. It might be for patient convenience, but it could equally be because that's when your test results are in, or that's when you're back from holiday. So there may be reasons that people themselves choose, or the clinical reasons that you get an appointment after that. Why do we get told to ring back? This happens when I ring my GP practice. It's a very common occurrence, unfortunately. And I think, again, this comes back to too much demand. The way GP practices work is they have a set number of staff, and therefore they have a set number of appointments on any given day. And they have a mix of kinds of appointments. Effectively, people who feel that they need an appointment more urgently, so they'd like an appointment quickly, and people who want an appointment more routinely, perhaps for a long-term condition they've had for a long time, or for a fairly non-urgent issue, and they'd like to book that ahead at their own convenience. And GPs are trying to juggle both things. Typically, they will hold about 60% they'll book about 60% for routine appointments, and then they hold a portion, typically about 40%, but it will depend on what the demand looks like on any given day for anybody ringing in with anything urgent. And they don't book endlessly into the future. So if you're, as we know, sadly, if you're trying to get a hospital outpatient appointment, you could be, or a hospital surgical intervention, you're put effectively on a waiting list, and it could be weeks or months, or sadly even over a year, and they hold a long waiting list. GPs don't do that, so they effectively are operating these much shorter timescales, and that means that they are releasing appointments every day, which unfortunately, practically for us as patients, means that you may ring and appointments are already booked, and therefore you have to ring back and try again until more appointments are released. And it's extremely frustrating, and we are trying to improve it, but that's the reason that this happens. So one of the questions I get asked sometimes is, well, surely there's been lots of investment in the NHS, lots of investment into general practice. Why have we still got this problem? And there's truth in that. As I said at the start of the presentation, since 2019, we've invested in Derby and Derbyshire nearly £24 million in staff, which is about 500, nearly 600 new people. The way it's been invested, and this is a national program, not a local decision, but a national program, to give it rather to individual practices, but to groups. And these groups of GP practices are called primary care networks. So your practice, all of our practices here in Derby and Derbyshire, will be part of a network. Now, the idea behind these networks and the idea behind practices working together is that it allows them to do things that individual practices struggle to do by themselves. It gives them more scale and more economy of scale. It gives them more people, it gives them more opportunity to kind of expand what they can do. And it also allows us to have this skill mix. So there's multidisciplinary teams, all of whom can do something different. You're not trying to channel everything through a very small number of GPs who are expensive and hard to recruit to and highly skilled, and are not needed for lots of things that can be done by other people in general practice and in primary care. So these primary care networks do a whole range of things. They support care homes, they do medication reviews, they provide anticipatory care for older people, they do some work on well, they do this kind of whole range of different services. And the kinds of staff we've employed are people like pharmacists, physiotherapists, mental health workers, social prescribers, which are non-clinical staff who try and link patients up with more social care, more social interventions. So all well and good, but what's the actual national plan? In 2023, the government, April of 2023, the government launched a programme called the National Primary Care Access Recovery Plan, and it had two main aims. One was to tackle the rush that we've all experienced at 8 o'clock in the morning when you're trying to ring through and told to ring back. And the second is when you do get through, that you know what's going to happen to you and that you are either seen and treated quickly, or you are given an appointment within a relatively short period of time, or you're signposted to the right service. And the plan had 4 elements, which I've listed there, which try to do a range of different things, a kind of multi-stranded approach, empowering patients so that we as patients can look after ourselves better, and know where to go better, improving how general practice works and supporting that, increasing the overall staff into general practice. And the last element there is trying to reduce the amount of work that comes back from hospitals to general practice, and to reduce the bureaucracy that GPs sometimes experience when they're trying to work with, refer to, talk to the local, particularly the local hospitals. I'll just go through each of these relatively quickly, and we can talk about them a bit more later. The first element, that empowering patients, had several strands. So it was around using the new NHS app, which hopefully some of you have and do use, but we now all have access to an NHS app, and all practices are linked to that and are promoting it. And the idea is that that's a better, more efficient way for people, where possible, to access services. We've also looked at improving how you might refer yourself without having to go through a GP. So many practices now have direct access for things like physio, so you don't have to go to the GP, which is much more efficient in terms of the GP time, but it's also quicker for patients. We have, and hopefully again people know about this, we have a new national Pharmacy First programme, which allows patients to go direct to the pharmacist for 7 common conditions, and allows GPs to refer to pharmacists and away from their services for those conditions. And we have are introducing more automatic GP registration. So previously, some of what GPs had to do was spend time registering new patients and spend appointments registering new patients. That's now been automated for many practices. Second element, modern general practice, a range of things here. We've spent a significant amount of money supporting practices to upgrade their phone systems. We've moved away from the old analog copper wire systems where you would just ring and potentially just be waiting with the phone ringing out. And we now have, all of our practices now have digital telephone systems which allow more supported waiting. So it's you hopefully when you're ringing, you're told where you are on the queue, you're given the opportunity to call back at a less busy time, and there is better and the practices themselves know better who is on the line and have got more opportunities to pick it up. We've also increased the online capacity for people so that you can go online if you rather than just having to either walk in or use the phone. We've supported training in practice so that the reception staff and other staff who first speak to you are supported to direct you to the right place. We're just introducing it at the moment, actually. There's a digital triage tool. So one of the things that we know works, there's really good evidence for, is that when you ring, you get to speak to a senior clinician and they can triage your need. So they can talk to you and they can ask you the right questions and they can get a sense of what kind of service you need and how urgent that service needs to be. And there's practices have done this, lots of practices already do this and have been doing it for a long time. They tend to do it using a senior clinician who uses their knowledge and skill. What the digital triage tool does is provide a kind of digital tool to support those senior clinicians so that they can use evidence-based algorithms to ask the right questions, to get the right answers, and then to use that to support them to make the right decisions in a consistent way. And then there's the last thing here is a general practice improvement program. So GP practices are often excellent at providing care and are often successful small businesses, but they often don't have a lot of expertise or knowledge in how to improve their own services, and they don't necessarily have the time or expertise to understand the latest thinking in, for example, how to manage queues, how to manage flow of patients through, how to manage the kind of services. And what we have done is, and what the government has done, is invested in an improvement, a kind of training and education program, which most now of our practices have participated in to improve and think about and improve how they provide services. The third element of the plan is around building capacity. So as I've mentioned already, we've put some significant investment, over £20 million, into these larger multidisciplinary teams. We have stabilised the GP numbers, and from this September just gone, the new government has allowed the PCN funding that previously we weren't able to use on GPs to be used to fund GPs. And I think we've got a handful of GPs in this first since September. There's 5 or 6 GPs who we've now funded through that, using that funding stream. And there's also a whole raft of things happening in Derby and Derbyshire to try and encourage and recruit and retain, particularly GPs and nurses. So we have we have a kind of portfolio approach for GPs where they can do other things to make their jobs more interesting and to make sure that they have a range of options and don't leave the profession or don't leave Derbyshire to do other things. So these things called GP fellowships. We offer support for young doctors, mid-career doctors, and doctors towards the end of their careers to try and make sure we keep them here in Derby and Derbyshire. And then the final part of the plan is around, as I mentioned before, the interface between secondary and primary care. There's some estimates and some reasonably good evidence that the work from hospitals accounts for about 20 to 25% of all of the work that the GPs have to do. And this has got worse over the last few years as hospital waiting lists have got longer, because GPs have had to spend more time effectively chasing hospitals on behalf of their patients, and patients who are sitting on waiting lists for long periods of time are understandably needing more GP care whilst they're waiting. And hospitals can, as I'm sure we all know from our own experience, be complex to try and navigate, and GPs have taken a role and are asked to take a role to try and advocate for their patients and to try and find out what's going on with the hospital. And this can be as difficult for GPs as it is for us as individual patients. So some of what we're doing at the moment is working with the hospitals, so we get, for example, single points of contact. So you're not as a patient, and practices aren't having to ring multiple departments to find out what's happening. So I've said there that there's four kinds of things that we're working on nationally. Eliminate this need to re-refer from one consultant to another. Make sure when patients do leave, they leave hospital, they come out with the right kinds of information. Make sure that when patients are going to hospital, the hospitals themselves are contacting the patients and it's not needing GP input. And then finally, as I mentioned before, there's single points of contact for patients and for GPs if you're waiting on a list. That was all of what I've just talked about was the national plan. We're also working locally, and the GPs themselves are thinking about how they might change and adapt and amend and kind of evolve their services. Typically, here in Derby and Derbyshire, and in fact across the country, GPs are working more and more in groups and together. Partly that's driven by these national primary care networks, and I think partly that's driven by an understanding and an awareness from GPs themselves that they need to work together, and that by working together they can offer more accessible and more resilient services. An example would be in Long Eaton, there's an on-the-day service where the GPs in Ilkeston and Long Eaton come together, pool capacity, and offer a service for all the patients from those the practices that contribute. We are also in the middle of reviewing our local services and the things that we commission locally, for example, phlebotomy services, and making sure that we are offering the right kinds of services and that we're paying the right amount for those services so that the practices can deliver them. That's me done. I'm going to stop sharing because I can't see anything other than my own screen, and it's been an extremely weird presentation, me just presenting to my own laptop. So I will stop sharing and rejoin you.
Thank you very much for that, Clive. There's a lot to unpack there. I'm sure you'll know there are a lot of questions in the chat. So what I'm going to do straight away is go right back to the start, and we'll do those in the chat. Then we'll come to any hands that are just being risen at the end. So the first question from John has said, some GPs in Derby have gone to jail. Do we have a major ethics problem and more GPs being investigated?
Well, that's a good question to start with, isn't it? Straight off the bat. I would say we don't have a major ethics problem. I don't know which GPs John is discussing. I'm not aware that we have had GPs go to jail in Derby. In my knowledge, we don't have a major ethics. There isn't a major ethics problem nationally. There certainly isn't in Derby and Derbyshire. It is true, unfortunately and sadly, that occasionally in the general, GP profession, as in all professions, you do have the situation where individuals do behave unethically, and that does happen. I do know that happens, and we have experienced that over time here in Derby and Derbyshire, as everybody has. But it's certainly not a major problem, and I wouldn't expect us to. We don't have a kind of investigation, any investigations or any GPs going, as far as I'm aware of now.
Okay, next one, Gabrielle has asked a couple. What is being done to clearly articulate to patients the purpose and value in diversifying appointment types, i.e. with AHPS of various disciplines?
That's a good question. There's a big national comms campaign and there are local comms campaigns, and on our website and our comms team has supported our practices to kind of provide some videos about what these other roles do, to provide GPs and GP practices with information that they can provide to their patients. Practices themselves are doing it. So there is quite a lot of comms, I think, going out. And then I think there's quite a lot of conversation happening in general practice where GPs and other staff are trying to talk to patients to say, you know, you've seen me this time, but actually next time perhaps you want to see this person, or receptionists through their care navigation training are saying this person actually might be better placed to see you, and they can see you quicker than this GP. So I think it's a work in progress, but there is work going on. In terms of patient choice, patients can ask specifically to see a doctor, and sometimes that is absolutely right. If you've got a long-term condition, or if you're in the middle of a course of treatment, and you know, and continuity of care is important to that treatment, then it makes a lot of sense for you to be able to see the same doctor every time. And all practices will allow that. Obviously, it may be that you have to wait longer to see the doctor of your choice. And the doctors themselves need to be careful, I suppose, not to get to a point where effectively they are seeing a very small number of people all the time to the detriment of all of their other patients. So it is possible. It's just a balancing act for the GPs.
Okay, the next one is not a question, but it's sort of something needs to be answered. There's a couple of these in the chat from Colin. So Colin says the figures don't add up in relation to my or Colin's GP practice. So this must mean that some GP practices are providing a far better service, thus overall making the statistics look better.
Well, I can't speak for that GP practice, and I can't obviously speak for Colin's experience. There are 112 practices in Derby and Derbyshire, and they're all separate businesses. So they will have different ways of working, and there will be some variation. There is. But in terms of the what we commission and the funding we allocate, it's broadly consistent. So we try as far as possible to allocate money in a fair way so that all GPs and primary care networks get their fair share of the money available. So yeah, there is some variation. I can't speak to that particular point.
Okay, next question is from Peter. As the people own the NHS through its constitution, why don't those employed to run it on our behalf prioritise doctors who will work full time when it comes to recruitment and appointments?
I think I would say the law is one thing. You can't. I think there's a legal obligation to make sure you're able to offer. I don't. What am I trying to say? I think legally there's rules about how you recruit, and I think there is an obligation to try and provide some flexibility. I think more practically, more pragmatically, there is the workforce, the demographic of the workforce now for general practice means that the majority of GPs, as I said, are women. The majority of GPs now choose or want to work less than full time. If we just wanted to recruit full-time staff, we would find that first of all, it's not the NHS that recruits them, it's the GP practices. But I think if the GP practices said we are only going to recruit full-time GPs, they would find that they couldn't recruit at all, because people would go to Nottinghamshire, they'd go to Manchester, they'd go to Sheffield, they'd go other places, they wouldn't come here. So part of recruiting GPs is making sure that we make this place an attractive place to work. Part of that is giving people flexible options. And I think the other thing is general practice is a really difficult job, and there's reason that lots of people want to work part-time, because it's a hard job to do well, and there's some merit perhaps in doing a better job for fewer days of the week rather than burning yourself out trying to do it full-time all the time.
Okay, next question is from Anne. Maybe one way to improve GP services to patients is to make them aware of what support voluntary services can offer, i.e. home from hospital. These days, the NHS is supposed to be integrated and collaborative, but how can they when they are unaware of services offered in the voluntary sector?
That's a great question. I think I mentioned earlier, didn't I? I think that's a really good question. That's a really good point. It's not a question, is it? And I would agree with that point. I think, and I think most GP practices would as well. The more they know about the alternative services available, then the better range of options they can give to people. And we know that, only 30% of our health is what am I trying to say? There's 70% of our actual health and well-being is as a result of non-health factors. So it might be the houses we live in, the jobs we do, our education, our social and economic opportunities. So most of our health is not linked to the health service; it's linked to other issues. But yeah, the health service feels itself responsible for it all, and sometimes takes responsibility for things it can't control. So I think the more we can expand that and think about non-medicalized support for people, the better. So yeah, I would completely agree with that. The last thing I'd say is that we have, as I mentioned before, a lot of primary care networks now employ people called social prescribers who do exactly this. Their job within a network of practices is to work out is to link in with voluntary and non-NHS services to make sure that they understand what those groups and people and volunteers do, and to make sure patients are linked in to those services. So there is increasing amounts of work going on to try and link these services together.
Excellent. We'll do one more from the chat, then we'll go to Valerie after that because her hand must be getting tired. It's been up for a while. So Valerie asks,
put something in the chat. Yeah.
You have, Valerie? Okay, I'll get to it later then. Thank you very much for that. Valerie's question in the chat is lots of good initiatives, but seems to be no appetite to look more fundamentally at general practice, e.g. should GPs be employed by the NHS?
Yeah, interesting question. So as people may know, since the establishment of the NHS in 1948, we have general practice has always been separate. So so they run as independent businesses. They contract primarily with the NHS. More than 95% of their incomes comes from the NHS, but they are still separate businesses. And there has been talk over the years about effectively nationalising general practice. So bringing it formally into the general practice, buying them out of their buildings, buying them out of their businesses, and putting them all on the books. And I think that will remain a conversation, a topic of conversation and an issue. And there are some people definitely who think that's the way to improve general practice, bring it in-house, nationalise it, and then you can kind of dictate to GPs more, and you can have more control centrally about what GPs do. Counter to that, though, I would say there is merit, a lot of merit in the current system. You have, where it works well, GPs who are senior clinicians who work in small teams, running their own businesses with a lot of skin in the game, very close to the ground, operating organizations that are very adaptive and can change and can develop and can operate outside of the bureaucracy of the NHS in a much more flexible way than the NHS in all its glory, but also in all its bureaucracy is sometimes able to do. So I think there is merit in a lot. I would suggest that there is significant merit in this independent contractor partner model, because it gives you that adaptability, that flexibleness, that almost unique situation where you've got really senior clinicians who also own their own businesses, skin in the game, very invested, very, very familiar with their own populations. So neither model's perfect, but yeah, the argument is still, the conversation is still live.
Mark, could I just my hand up bit of this to pick up what Clive has said there? I mean, I couldn't disagree with you more about having a private business at the heart of the NHS. And some of the things you've said yourself has actually challenged that model. You talked about 101 practices that are all separate businesses who have different ways of working, and that often gets in the way of patient care. For example, when you're looking at follow-up to heart surgery, which I sadly had to do because our doctor, which is a fantastic surgery, they're great there, had a different system to the post-care arrangements, and they didn't talk to each other. So I'm disappointed that you're not even putting it on the agenda for discussion, and I'm sure it must discourage a lot of people. You know, today's report, which is raising the issue of recruitment into general practice, you must have a lot of young people, particularly from working class backgrounds, who wouldn't consider it because, you know, running a business is so sort of alien to you know, where they're coming from.
Yeah.
Being a doctor. So okay, you know, I respect your view, but I do think it ought to be on the agenda for discussion, and I thought that was Wes Streeting's view as well.
Okay, if I could just come back on that, it's a fascinating conversation, and we could spend all afternoon on it. I think first of all, it's a national conversation rather than a local one. You know, this is a national decision. It's a national contract. We couldn't in Derbyshire nationalise general practice. By definition, it's national. I think you're absolutely right to highlight variation. I think that is the key issue, and obviously variation can be good or bad. And you're right that with multiple smaller organisations, you can get more variation for both good and bad. But it's also true to say that, you know, hospitals can be very varied. You know, the big acutes can have real variation within their the way that they operate, and certainly even within a hospital, they can be very varied. And between, so I don't think necessarily nationalising it will eliminate variation. I think the last point I would make is you're absolutely right as well that the model itself is proving challenging to operate even for partners. So we are seeing, as I said, the traditional model would see you become a GP, you rise to become a partner. There may be 4 or 5 partners in the practice, 3 or 4 partners in the practice, and a couple of salaried doctors, and you effectively are the master of the practice or the mistress of the practice as the partner, and you own the business. But it means you're tied in and you run it and you own it and you own the building, but you're there for 25 years. And if you want to sell it up, you have to find somebody else to take over and buy you out of your partnership. And increasingly, younger GPs don't want to do this. And that's why we're seeing fewer and fewer partners and more salaried doctors. So you can get a situation now where you've got 1 or 2 partners running big practices with maybe 10, 15 salaried doctors. So we are seeing those changes happen. And I think that will continue. And so I think whether or not we kind of nationalise it, or whether the model itself changes and you see these kind of bigger practices emerge with more salaried doctors, I think is still a live conversation, and it is a national conversation. But yeah, I just wouldn't want to think. I suppose I think it's easy to think, oh, it'll be easy. It'll be much better if you brought it all in house. I'm not sure. I think it's a bit like we used to think bigger practices are better than smaller practices for that reason. But I think that I don't agree with that either. I think it very much depends on the practice.
Okay, the next question is from Tim. As the funding provider, does your relationship with the practices define an expectation or target for appointments accepted that they are measured against?
That's a good question. No, we don't have a set number of appointments, but we do look at the total number of appointments offered by each practice, and we look at the patient survey, and we look at activity, referral activity, and we try to understand which practices look like they're struggling and which practices look like they're offering better access and which practices look like they're not offering such good access. And then we go and speak to the practices where we think we speak to both sides, which ideally we speak to the ones that seem to be doing really well to see what they're doing so well, but we also try and speak to we do speak to the ones that look like they're not doing so well. We try not to make that, we don't start by going in with a stick, we start by having a conversation, because it's important to understand what the situation is. Every practice, as we've just said, can do different things differently. And it may be that for their population, they're operating a particular model that works really well, but we challenge where we think they look like they are struggling more, and we try and offer support. And we could potentially, if we felt they were really failing patients, and that we felt they were in breach of their contract, we could go and operate. We could offer a contract breach. We could give them a contract breach and kind of demand that they change their service. We don't tend to use that unless we absolutely have to.
Okay, next question is from Pete. What progress has been made since you and Pete met a year ago? So I think you did this presentation about a year and a half ago, something like that.
Oh, okay.
In removing the burden of secondary care's referral management from GP practices, and specifically, are you saying there is now a single point of contact for patients to chase referrals rather than call their GP?
There has been some progress. I'm not saying yet that we've got it cracked, that we haven't unfortunately got a single point of contact. Both Chesterfield and Derby hospitals are in the process of putting in new and hopefully improved approaches to this. So they're both looking at single points of contact to try and coordinate that better. It's a separate conversation. Probably there's quite a lot of work gone into this. It's probably a conversation for another time, but it's been relatively slow progress over the last several months. We've seen them kind of leap forward a bit more, and we're hopeful that in the coming year, so in 2025, we'll see that really progress. But it hasn't been as fast as I think we would all have wanted it to be.
But Clive, could I just come in at that point? You know, if you were really serious about improving GP access, you know, potentially that single point of contact for patients could potentially remove 25% of the GP's workload. You know, it's a big thing that would really enable GP practices to offer more appointments to new patients if they're not bogged down in managing referrals that secondary care should be looking after. You know, it's a really big issue.
I completely agree. I'm not sure it's as much as 20. I think the 25% is everything. So it includes, you know, managing letters back. It includes dealing with people because they've been on the waiting list a long time. It's not
28% at our surgery.
Yes,
28%.
And my understanding is that's work. That's not just GP time chasing referrals. That's lots of different things. But you're right.
Yes,
it is a big chunk, and I would agree. You're right. That I think that if it's not to make excuses, because we are working with the hospitals, and I think we're all keen to push this on as quickly as possible. I think that one of the problems we've had recently, as people will know, is that the hospitals themselves are really struggling for capacity. They're managing. They've been managing extremely long waiting lists, so they have been on this kind of treadmill and struggled to get their head up to see how they could manage things differently, because the staff that they have been busy trying to manage the work that they, you know, the backlog of work they've got. So it's hard to change to fix the aeroplane wing while you're flying, I suppose. But you're right. It's absolutely. I think that's true. And the more we can do, and the quicker we can do it, the better it will be. But the hospitals themselves, it needs to come with it. It needs to be driven by the hospitals, and they are, as I say, they're working on it. They're struggling with capacity.
But the hospitals haven't got a vested interest, Clive, have they? Because by not managing the referrals, it automatically means GPs and practices have to take up all that slack. So by default, they get the, you know, the bad end of the deal, don't they?
I think that's true too. Although I would say that it's not. I don't think they're doing it in a conscious way. I think they are also seeing this rise in demand across the board. So both sides are feeling the pressure. I think you're right, though, that some of that work that falls into general practice is hidden from the hospital, so they don't see it. So it's not being as urgent for them as it has been for the GPs. And part of what we've done we've got a primary secondary care interface group, is to bring GPs and hospitals together to say, within how can we sort this out? Come on, we've got to sort out single points of contact, for example. What are you doing, and how can we make sure that it works? So there is work going on.
But Pete, we do need to move on to other people's questions, rapidly running out of time. The next question is from Tim. Are you able to do, or are we able to set the expected approach to access? For example, is it acceptable for a practice to refuse to offer any appointments other than those on the day? This at present is not consistent across the ICB and promotes the 8 a.m. rush.
We would expect, we do set there is an expected approach, and we would expect practices to offer a mix of on the day and more routine appointments. But we also allow a degree of flexibility, and we couldn't police, it would always going to be difficult to police this. For example, immediately after the second week in January tends to be an extremely busy, or is always an extremely busy week for on the day demand, because it's a particular week where people are coming back from their holidays and often then come down with sickness. So that week practices may decide the demand for on the day is such that they have to change their mix of on the day and routine. Another week they might change it back. They're it's a live system. They're constantly trying to manage the demand and manage that balance between on the day and routine. So me sitting in my office in Derby saying, right, from now on we expect everybody to do it like this, would be, I think, extremely unhelpful. I think we need to allow some flexibility. But you're right, or the implication in your question is right. We also have some expectations about what is normal, and it goes back to that idea that I said before, which is we do track this, and where we see practices who appear not to be offering a reasonable blend, we will go back to that practice and challenge them.
Okay, the next question, and then we'll make a plan as to how to end. The next question from John, really quick one. Is it £250,000 salary for partners?
No. I mean, partners don't get a salary. Partners own the business, so they take the funds that are available after they have paid all of their costs. £250,000. I'm not saying that there aren't partners that wouldn't, that no partners ever receive that money, but it's significantly higher than the average. The average is much lower than that, and I think you'll be able to see on your practice website what take-home pay income is for GPs. So I think GPs are obliged to show that. So you should be able to see for yourself, but that's much higher than you would expect.
Okay, Clive, we have 4 more questions. I'm not aware of what's in your diary, so I guess it will be up to you. I don't know if you have other appointments. If you don't, is it possible to carve out another 5 minutes?
Yeah,
if not, we can respond to them after in the Q&A.
No, I'm happy to do that.
Okay, that's what we'll do. So if people want to stay on the call, we can do that. Thank you very much for that, Clive. So Ariana has asked, has the impact of lack of GP accessibility on walk-in centres and A&Es been researched? You mentioned the funding for nearly 600 new staff. However, this has been split between non-GP roles. Is it shown to be effective and a good use of funding? So, for example, social prescribing, when there are other roles in the community who provide similar roles, this funding could be used for more GPs.
I think the short answer is there's lots of research going on in this area, particularly nationally, but there's no absolute conclusions yet. This is one of those areas of, I suppose, real world research, which is very difficult to measure. So because you've got so many variables, and it's very difficult to understand what is impacting on which. So the A&E and UTCs, urgent treatment centres or walk-in centres, have seen a rise in demand over the last several years, and general practice has also seen a rise in demand. It's very difficult to know for GP, for ED, A&E, sorry, and walk-in centres, to what degree that rise in demand is due to a lack of capacity in general practice, and to what degree it is just because, as I mentioned at the start of this conversation, we're seeing an increasingly a population that is increasingly elderly, that has increasingly high needs, and increasingly has, understandably and rightly, has an expectation that the health service can provide for those needs. So I think it's really difficult. It's almost impossible to know whether, to what degree GP access impacts on walk-in centres and A&Es in a kind of a scientific way. But it's also true to say that in general practice, we offer 570,000 appointments a month. EDs and urgent treatment centres and A&Es are tiny by comparison. Tiny. They're offering a tiny fraction of those numbers of appointments. So the smallest ripple in general practice is potentially going to cause a tsunami in an emergency department in a hospital. You would only take you 2 or 3 practices closing in a town centre, and those patients on any given day going to their local urgent treatment centre to kind of swamp that urgent treatment centre, for example. So I think my guess would be that if you really wanted to sort out urgent care, you would invest very, very heavily in general practice and community services. But you would have to do more than, you would have to invest significantly because of this rising demand. The second part of the question is a good one. There's again, it's one of those live conversations. There's a school of thought that says, as I mentioned before, a lot of healthcare has been our health and well-being has been over medicalized, and we need to move people away from thinking that there's a pill for everything and the GPs can sort out everything and that healthcare can do everything. And we need to think more about the wider determinants of health and how housing, jobs, employment, and other things are really the bigger factors in our well-being. How loneliness is an epidemic that can have really detrimental health impact, and a GP is never going to be able to sort. So there's one school of thought that says demedicalize, expand the range of care, the range of services available, and bring and improve and lift well-being and health that way, which is entirely legitimate and evidence-based. There's another school of thought that says that's not the role of health services, and actually what we should be doing is investing all our money in additional general practice or GPs or doctors or nurses, which is also a reasonable approach. I think, at the moment we've got this balance, or we're trying to have this balance of both. And in the last few years, as I've said, people have invested more, the government has invested more in these non-GP roles. I don't think we'll ever quite get the balance right, and I think it's going to be difficult to prove whether how and when that balance would be right.
Okay, Clive, we've eaten into those 5 minutes already.
Oh, sorry.
There are tons more questions left. Unfortunately, we can't do all of them. Perhaps if and when we do this session again, we'll maybe carve out more time.
What will happen is,
I was going to say, Clive, I'll forward them all to you, and then for the people on the call here, everything, all the Q&A that we've already covered will be covered in the Q&A document. Those that haven't yet been answered, I'll forward to Clive, and we'll get a formal response to all of those. That Q&A document, it may take a few days to compile, depending on Clive's availability, of course. But keep your eye on the Derbyshire Dialogue page, and it will appear there. So in bringing the session to an end, first of all, I'd like to thank Clive Newman for an excellent, really insightful presentation. There was certainly a lot to unpack there, a lot of understanding, and it generated more questions than we've had on any other session, and quite rightly so. I'd also like to thank the audience for attending today. We put these sessions on for you, so without you this can't be possible anyway, and we hope that you all took something good out of it. If we look forward, the next Derbyshire Dialogue is going to be on children and young people's mental health crisis response. That will be on the 22nd of January. So not long after today, what will happen is I'll send an email to all attendees saying that the recording of this session has been uploaded to the website, and you'll also have an invitation to sign up to the next session. So thank you, Clive, again, and thank you everybody for attending. Bye-bye.
Thank you.
Well, do you want to send me these questions then and I'll answer them? Or do you want me to answer them in the chat? How do you want to do it?
I'll send them to you, Clive. You'll have a live link to a document where you can go and update everything you so wish. And thank you very much to everybody again. Bye-bye.
Thank you. Bye.